don't know that. I am going to go through, though, what currently is kind of the best evidence. I think the biggest thing, if you walk away with anything, is where we should put our money, time, and effort in this world and where we shouldn't. Because I continue to see a lot of things going on that are sort of like, really? Why bother? So think about it from that perspective. I have no disclosures. I'm not working with any drug company to create the pill yet. We're working on it. So falls, we all know, are a significant cause of injury and death in older adults, especially those who are frail, and really the population that we work with in long-term care. Residents in long-term care facilities fall for a variety of reasons. Sometimes we think we know them all and one more comes in. And they are also, unfortunately, more likely to endure injuries after a fall. So what do we know about what works? And if I went around this room and everybody on a line and asked what they believed helped prevent a fall, it would be a fascinating little survey. Because we're all sitting here and we all have a very strong thought and bias. You can listen to everything I'm going to say. Hopefully I'll change somebody's beliefs maybe a little bit, but we really tend to act on what we believe. And if you really shut your eyes, think about what in your heart and soul you believe prevents a fall. And unfortunately, I know many nurses who truly believe if we put them in bed and kept them there, all would be safe, sound, and perfect. Look around and watch. So think about the individual that's doing that, and it's not just teaching, but it's changing how people believe. Most of you in this room are believers, probably in all the things I'm going to say by virtue of the fact you're here. But think about that in the bigger world we work in. So with regard to screening and assessment, wow, this is a big one that we spend a lot of time on. There's in fact very, very limited support that it does a darn thing. Screening and assessments are really useless unless we use the information. To do an assessment is worthless. We know that everybody in long-term care is at risk for falls. Most of us sitting in this room or are getting older are at risk for falls. I don't know about the rest of you, particularly women in here, but I fall all the time. I took a lovely slide the other day walking to work, right over a metal grate. Who knew? There was no choice. It was icy and slippery, and I was walking, carefully, but there I went flying, and you know what? I had tons of padding on. Thank God for the cold weather. So screening and assessment, if you're going to do them, it's most effective if the following things are included. A focused history. So really looking at prior falls, not just that kind of nonchalant, have you ever fallen before, but getting the gory details. Yes, I fell 12 times last month, all going to the bathroom. What meds is the person taking? What medical problems, what comorbidities do they have, particularly musculoskeletal issues? A physical exam, unfortunately, and this is one of my bugaboos, but the biggest thing that gets lost on a physical exam, musculoskeletal and neurosystem. They're critical for falls. There's people that just walk, they're walking, they're stepping on their own toes. I mean, that's a dead giveaway, but if you haven't gotten that person up and evaluated, how do you know? And it's often missed. Foot exams, plantar and dorsiflexion, it only takes a second, but it doesn't get done. Look at the admission H&Ps in your facility. And then whether the admitting physician does it or nurse practitioner or nurses. Functional assessment. What do people do in terms of ADLs? We tend to look at that. One thing we forget to look at is fear and the impact of fear. Sometimes fear can be a good thing with regard to falls because it makes us a little more cautious. But For some people, it freezes them, and that's going to be a problem when we talk more about the benefits of exercise. And then environmental assessment. Sometimes we spend a little bit too much time and focus on that, and we'll talk more about the efficacy, but really thinking more focused on those areas. Relevant things to look at after a fall. Post-fall clinical findings, and this is the most exciting time. Why? This is where you can get the information to prevent the next fall. You can't do anything about the thing that happened. Unfortunately, here we tend to focus a little bit more on, is the person hurt, not hurt, on to the next one. And I have to admit myself as a provider, on a busy day, I'm like, just tell me they're okay and I'm going to deal with the acute medical problems. Unfortunately, and I try and teach students, every fall is an acute problem. It's an acute problem that needs to be worked up until we know it was because they were wearing some god-awful pair of shoes or something. But it really is an opportunity that gets missed. What are the things to look at? Vital signs. I really work hard on teaching nurses how to get orthostatic pressures and heart rates, because you can sometimes pick up a contributor. Pain, swelling, bruising, things that we look for automatically, although we have to think a little logically there. In that first 3 seconds, is there going to be a bruise? Really? No. It's the next 3 days. Is there going to be a subdural hematoma in 5 minutes? No. Even if you're on Coumadin, it takes a little accumulation time. So it's thinking logically and timing that process. Should we spend 3 hours on looking at every part of the skin then? Probably not. Let them go have lunch and come back. You'll check later. It's not going to change anything. Give them a bag of ice, sit on it, whatever. Changes in function or cognition are certainly indicative of an acute medical problem. And also sometimes just the lack thereof. This person is at their baseline. I'm ruling out this horrible acute problem. How often and how long to evaluate residents for? No one knows. This is where good clinical judgment comes in. To have rules, and we'll talk about the neurochecks in a little bit, but really it should be based on the type of fall, what you're expecting, and what to look for. Whether a patient should be transferred to the hospital or not, well, these days so much of it depends on whether they're palliative care, whether the caregiver has clicked off, I don't want any hospitalization. So a lot of it is controlled by other factors. But if you think about clinical judgment, certainly if there are situations where you just can't stop the bleeding and you've put every steri-strip on unless you can pop some sutures in where they are, that would be something that would be considered. And then I always consider anything that looks like a true orthopedic fracture that could be fixed and could make somebody feel better. They should have the opportunity to have that fixed. And so more around limb deformity. Certainly acute change in neurological status or cognition probably can be evaluated, particularly here, because they're probably going to get sent here if it's a real confusing problem. Mythbuster. It is common practice in many long-term care facilities to do frequent vital signs or neurochecks. However, there are no studies to demonstrate the efficacy, or there's nowhere in any, I've looked through the oldest nursing texts I can find, there's no evidence to do this. And it always kills me if those of you who are healthcare direct providers in the room, if you look in any older adult's eyes, by the time they've had 3 cataract surgeries and everything else, it's like, we have no idea what we're looking at, and you're seeing some fixed pupil in some god-awful shape anyhow. So it's really a waste of nursing time. Maybe they could spend that time walking somebody to the bathroom instead. I think these are the things to really take back and consider, and we have the evidence that says no need, no efficacy. There's no evidence supporting observing patients for a fixed period of time after a fall either. There's no regulatory requirement to do so. Performing a past fall evaluation after a fall, we should obtain that relevant history regarding the circumstances, their current meds and med changes, postural blood pressures and pulse, gait and balance evaluation, and then certainly looking at the environment. And I will tell you assistive devices, because often I've seen falls that happen just because those things are worn out and the old favorites or whatever, and it kills me, like the brakes are gone or the tips are gone. There are some examples of interventions that have been used kind of more globally throughout facilities to try and reduce falls or the consequences of falls. And there's some evidence for all of these in terms of working, not alone, and we'll talk more about that, but in any variety of groups and options. So activities, programs, why? They keep everybody in good view. Function-focused care are optimizing function and physical activity. Programs to help patients and families cope with and adapt to non-modifiable risks. If your balance is impaired, we often can't fix it. How can we modify it? How can we work with you safely? Programs for patients who wander, reduction in the use of physical restraints, and I'm sure you guys have a good deal of expertise here, and I think we've done a very good job of that in long-term care compared to our acute care colleagues. Rehab programs, staff education about fall risks and potentially helpful interventions, toileting and continence programs, and the use of hip protectors. Some focused interventions that have been shown to work, so more focused at the individual versus facility.